The sentinel event for fatal falls. And the statistics are that every year in the United States, hundreds of thousands of patients fall with 30 to 50% resulting in injury. And that's just in the hospitals. Okay, injured patients are required additional treatment and sometimes prolonged hospital stays. In one study, a fall with injury added 6.3 days to the hospital stay. And the average cost for a fall with injury is about $14,000. And they're also the number one sentinel event according to the Joint Commission. Okay. Most common contributing factors to falls are inadequate assessment, communication failures, lack of adherence to protocols and safety practices, inadequate staff supervision or staff orientation, supervision, staffing levels, or skill mix, deficiencies in the physical environment, and lack of leadership. So the successful strategies to prevent falls include the standardized assessment tools to identify fall and injury risk factors, such as the ones we do during our clinicals. The assessing the individual patient risks that may not have been captured through the tool. Interventions tailored to an individual patient's identified risks. And systematic reporting analysis of a falls incidents are important components of falls prevention program. Okay. So according to this slide, falls with serious injuries are consistently among the top 10 sentinel events reported Joint Commission event database, sentinel event database. They're actually the number one sentinel event according to the Joint Commissions. And then in 2009, 465 reports of falls with injuries were submitted to the Joint Commission, with the majority of these falls occurring in hospitals. Approximately 63% of these falls resulted in death, while the remaining patients sustained injuries. In addition, ECRI Institute reports a significant number of falls occurring in non-hospital settings such as long-term care facilities. So that was 2009, and they had 465 reported falls, with 63% of those resulting in death. So only 63% of those were sentinel events. In 2021, there were 1,197 total sentinel events reported to the Joint Commission, so patients died in almost 1,200 events, and 485 of those were caused by falls. So the number of deaths apparently went up. And that's what I have updated for that slide.
As we can see, falls resulting in injury are a prevalent patient safety problem that we probably have all seen, and we can see with the statistics. Our elderly and our frail patients with known fall risk are not the only ones who are vulnerable, however, to falling. Any patient can be vulnerable, even any age or any physical ability can be at risk due to psychological changes such as a medical condition, medications, surgery, procedures, or diagnostic testing that can leave them weak or confused. So our first step is to lead an effort to raise awareness of the need to prevent falls resulting in injury. We know the statistics, so how can we work with our other staff members? We can communicate safety information to clinical and non-clinical staff at every level of our healthcare team. We can incorporate safety precautions into the full continuum of patient care and education by applying change management principles and tools, and that includes including how to set the stage for success, make the changes easy, and empower our staff to make those changes. And as we do that, we can support a robust change management effort and empower an executive sponsor to ensure adequate equipment is available and resources.
Do you want the next slide?
Yeah, I got it. Oh. The Joint Commission recommends the following actions to help healthcare organizations prevent falls and fall-related injury. To prevent falls, requires leadership, commitment, and a systematic data-driven approach to achieve risk reduction and continuous improvement within specific settings and among specific populations. Reducing falls resulting in injury is everyone's responsibility. So that includes everybody on our healthcare team, especially nurses and physicians, but also environmental services, IT, patient advocates, our pharmacists, physical therapy and occupational therapy, and quality and risk management. So So another step we can use is use a standardized validated tool to identify risk factors for falls. So we use these at the clinical site more often as the Morris Fall scale. But as we have that in there, that's integrated into our patient medical record so that we can see what could lead to a fall, and such as cognitive status, age, gender, and level of function. And we can also provide training to the staff on using the tool to ensure that we have reliability and the degree of consistency among raters is high. We also can develop an individual plan of care based on fall and injury risk that we identified with this assessment that we did, and implement interventions specific to a patient population or setting. Because we know that all patients are at risk, we can create an individualized plan to help each patient where they need it most. Okay. And we also need to standardize and apply practices and interventions demonstrated to be effective, including such things as whiteboards to communicate with our staff and our healthcare workers, as well as communicating perhaps at the bedside about fall risk with the patient, and also when we involve the patient, we have a higher rate of satisfaction and less falls.
Is that this slide or am I too far ahead?
Huh?
Is that this slide or am I too far ahead?
It's not moving for me. We also need to conduct post-fall management, so that would be a huddle of all our team members to see what factors led to the fall. And it also is very important that at this point, we're honest with each other, we're transparent, and that we identify risk and things that we can prevent in the future.
Okay.
Eileen?
Oh.
You gotta tell me when to go to the next slide.
It's not changing.
It's not changing at all on that side?
No.
Oh, okay.
Okay, so conduct a post-fall huddle as soon as possible after the fall. So what we need to do is to make sure we involve all the staff at all levels, and if possible, the patient should discuss the fall. We want to make sure to know what happened, how it happened, and the factors that led to fall, such as physiological factors due to medication or medical conditions. In addition to that, the huddle should include whether appropriate interventions were in place, specific considerations as to why the fall might have occurred, including but not limited to whether the call-out was on and for how long, staffing at the time of the fall, which environment of care factors were in place, such as toilet height and design and slip and trip hazards, and how similar outcomes can be avoided. Also, how can the care plan be changed or how it will change. We want to make sure to report, aggregate, and analyze the contributing factors of an ongoing basis to inform improvement of efforts. The analysis should be done in a data-driven, systematic manner to discover factors that are significant in your setting. This will lead to solutions that target these factors. This helps the falls prevention team to continually reevaluate and improve the approach to patient falls prevention and injury reduction with specific settings and among specific populations when indicated. As continued with the reassessment of the patient, an important key for fall reduction is to know patients who have fallen in order to identify sooner rather than later a change in a patient's medical condition that can precipitate a poor patient outcome, such as subdural hematoma or undiagnosed fracture, including medication changes, cognitive and functional status.
Are we playing this video?
We can, or just I was just going to say that these are some videos that you can look up on the Joint Commission's website if you want to look into further things that they're recommending.